Hi, I'm Dr. Jared Gardner, and I'm here today with one of my pathology residents, Dr. Iman Sarami, and we're going to go through a set of soft tissue unknowns. So this is unknown set number 1, and we'll get these slides scanned eventually to share online. Okay, so I gave Iman these as unknowns and told him to figure them out, and then I gave him some questions to try to sort through. So what did you think about this one? This is, let's see the history here. This one, Iman, is a 25-year-old man with a lower thigh mass. So what's your diagnosis for this? What do you think?
I think it's a monophasic synovial sarcoma.
Excellent. Very good. It is synovial sarcoma. So how did you figure it out? What features did you think were helpful?
It's like a dark blue cells, like they get spindly, like monotonous growth and cystic formation. Mitosis.
Excellent. Yeah, I think that's a good point, that they're very monotonous, uniform, kind of plump, like slightly fat spindle cells. They're not real thin and long. They're kind of fat and plump and rounded, and they're real closely packed together. So it's very cellular, which gives it a very blue-purple appearance usually. And see, looking close, there's no pleomorphism here because these are translocation sarcomas, right? And usually translocation sarcomas don't have pleomorphism most of the time. Now, like you said, though, mitoses are often present, and sometimes they can be abundant, but there are sometimes areas that don't have very many mites. The other thing is the cells do tend to run in these kind of long, streaming fascicles. Sometimes the fascicles can intersect at sharp angles and be like the so-called herringbone pattern. And like you pointed out, this one has a lot of cyst formation in it. And sometimes synovial sarcomas will make cystic breakdown in them. They can have areas of hemorrhage. They can have calcifications in them sometimes. And sometimes also they can get areas that are kind of hypocellular. I have seen areas like this that get almost like a little myxoid change and they lose the hypercellularity. I've seen areas like this on small biopsies where I really struggled to recognize it. And on excision, I was like, oh, it's a synovial sarcoma, of course. It was really surprising to me because usually you think of the classic areas as being very cellular. And then synovial sarcomas often have dilated branching staghorn kind of vessels. Like see these dilated open vessels, similar to the vessels you see in a solitary fibrous tumor. So I think solitary fibrous tumor and synovial sarcoma can be a really close mimic of each other sometimes. And you can sort that out with additional testing. Let's see. So what kind of, let's see, what was the next question on the sheet? What kind of molecular abnormality do you find in synovial sarcoma?
SS18, SSX.
Yes, exactly. SS18 with SSX either 1, 2, or 4. And here's an example. Look at how hypocellular. If you just had a picture of this, man, I wouldn't think of synovial sarcoma. I don't know what to think of it. It's hard to imagine now, but I mean, you'd wonder about a lot of other stuff. Looks pretty benign right there, but this is actually still part of the tumor. So yeah, SS18, SSX you can test for with FISH or RT-PCR. I usually like to do the break apart. And now there are immunostains actually to help detect those abnormalities, which is a really new thing that I haven't had much experience with yet, but it's pretty cool and they're supposed to work really well. The SS18 immunostains, and there's a immunostain I think separately for the fusion. So that's pretty good to know. And if those of you watching at home, I've got a whole full long video about synovial sarcoma, so I'll put a link down below, or you can search for it on my YouTube channel and check that out. That's a pretty classic area right there, that streaming, plump spindle cells and the uniform nature of them, how they don't really have any pleomorphism. That's really key. That's a very characteristic, helpful finding. What immunostains, aside from the SS18, SSX, what immunostain profile would you expect for synovial sarcoma?
I think the keratin, EMA positive, TLE1.
Excellent.
CD56 and CD99 is also.
Yeah, CD99 stains a bunch of stuff, right?
Yeah,
and I think people
exactly.
Yeah. I tend to only use CD99 personally, like in the setting of a round blue cell thing where I'm thinking of Ewing, and if it's negative, then it's probably not Ewing. So it's a very sensitive test for Ewing, but other than that, it's relatively non-specific, so I personally don't use it very often. I think pankeratin and EMA are great stains for synovial. They often will be kind of patchy and focal, so you can have big areas that don't have staining. They obviously, when you have a biphasic synovial, they tend to really light up the epithelioid cells, making the little glands, but also you should see some scattered staining in the spindle cells. So those are great stains. TLE1 should have strong diffuse staining in the majority of synovial sarcomas. I personally have kind of mixed feelings about TLE1 because I've seen it stain lots of other things that are not synovial sarcoma, like including solitary fibrous tumors and other things. So I tend to, if I'm having trouble with it, I usually just go straight to the molecular personally, because I feel like TLE1, I've seen enough times where it really confused me. But I know a lot of people who like it. And certainly if TLE1's negative, that's a good argument against synovial sarcoma. Because it's relatively sensitive. I can't remember the exact number, but it's the majority of them will stain. So that's good. And one other thing that's kind of helpful, CD34, which is definitely not a specific marker, but it is usually negative in synovial sarcoma, as opposed to like SFT, which will be strongly positive for 34. So the lack of 34 can be helpful. And one final point is that Dr. Weiss brought up to me is that S100 often stains synovial sarcomas. I think it tends to be patchy and not diffuse and strong. At least I cannot personally recall seeing a case that was strong and diffuse. But she did point that out to me, that that's a pitfall, that to watch out for the fact that just because S100 is positive, that's definitely a known thing that can happen in some synovial sarcomas. So good to know that. So a good example here of a kind of cystic synovial sarcoma that's maybe a little bit unassuming at first, but definitely a good example. All right. Now, excellent job. Now, case number 2 is a 30-year-old female with a stomach nodule.
Yeah, that was actually the difficult one. It made me think a lot. So it's. I think
here we
it's
got
like
muscularis out here, right?
Yeah, it's like a. And then it's like a vascular tumor, and then it has like a kind of cubital cells proliferating around it, and like some of them have like a perinuclear halo around it.
Okay, let's go in closer and look here. There are a lot of dilated vessels. You are right about that. And there are these very round or cuboidal, if you like that terminology, cells kind of around those vessels, yeah. Do you think that those are endothelial-derived cells, like a true vascular?
I thought about like a glomus tumor at the beginning,
Well, that's very good, because that's what it is. It is a glomus tumor. Not as difficult as you thought when you got it right. Yeah, and so these look vascularized, but they're not truly vascular neoplasms, right? They're not neoplasms of endothelial cells. And you can kind of see that when you look closer, you can see that these are endothelial cells in here, but the tumor cells are separate, like they're out around the outside of the vessels.
Yeah.
So sometimes that can be a helpful trick when you see a very hypervascular tumor with lots of vessels, and you wonder, is it, angiosarcoma or hemangioendothelioma, something like that. When you look close and see, oh, the endothelial cells are definitely distinct and separate from the neoplastic cells, that can help you sort out, oh, it's not really a vascular neoplasm. It's a neoplasm that has a lot of vessels in it. And I've seen practicing pathologists really struggle with that and get it wrong, and it can make a big difference. So these are actually tumors of what kind of cells are glomus cells, do you know?
It's like, I think, perivascular.
Yeah, they're pericytes, right? They're perivascular modified muscle cells called pericytes. That's the type of cell that the glomus cells are recapitulating. And of course, they're named for these little glomus apparatus that are usually out under the nail bed and the fingertips, or also known as the canal of Souquet and Hoyer. And anyone out there who speaks French, I apologize, because I'm sure I'm terribly pronouncing those names, but they're little arteriovenous anastomoses. But we can see glomus. Obviously, the nail bed is a good site for glomus, but you can actually see them anywhere in the body. Internally, when they involve the internal organs, the stomach seems to be, I think, the most common site, if I recall. Certainly, it's a well-described site, and it's important because think of the other tumors that occur in the wall of the stomach, things like GIST and stuff like that. So you want to make sure you don't confuse this, because the significance is different. So like you said, the cells are very round and monotonous. They wrap and circle around the vessels. They kind of make a layered appearance that some people like to say onion skin. I think onion skin is highly overused in pathology, so I try to avoid it because everything says, oh, this and that is onion skin. And I just feel like it's a little overdone. But I do think it is helpful that the cells do tend to run in these like kind of rows, though. So whether you call it onion skinning or whatever, the cells wrap around vessels, and they do tend to kind of have an organization or a pattern to them that's kind of parallel. And I like your point about that they have halos. You don't always see that, but seeing some degree of pale or clear cytoplasmic change is pretty good for glomus. That can be really helpful. And sometimes it can be prominent and really trick you, make you think it's an epithelial tumor. Like in the skin, they can look a lot like skin adnexal tumors. I've seen cases with a lot of clear cell change that, were really tempting to think, oh, maybe it's a hidradenoma or poroid type of tumor. And in fact, it was a glomus. And then also they tend to have a lot of edema or even myxoid change in between the nest of cells. That's not always there, but a lot of times you'll see the cells kind of floating around in this background. So, okay, cool. So this is a big one. And, you know, in the skin and soft tissue, if we see a really big or deep glomus, we get worried that it might be an actual malignant glomus. But in the stomach, the rules that we use elsewhere for benign and malignant don't seem to kind of apply the same way. This is still an area that's not fully fleshed out, but I remember Chris Fletcher gave a course once, and he was talking about that if I recall, and I hope I'm not misquoting him, I'm sure someone will point it out if I am, but then he said that the majority of these seem to behave indolently, even though they're large and deep, and so they're, you know, in the periphery, like in the leg or the arm or something, we would worry about a big, deep glomus, but in the stomach, it doesn't seem that they act badly. So anyway, really, really nice example of a gastric glomus tumor. These are perivascular cells, but they're not endothelial. So they're going to be negative for CD31, ERG, and CD34 usually. And what they'll express is actin, smooth muscle actin, because they're pericytes, they're modified smooth muscle. Usually they're desmin negative, but they stain with actin. Although in my experience, the actin is not always diffusely strongly positive. It can be kind of patchy. The other thing that I've noticed that you can use sometimes, you don't usually need it, is, let's see if we can get it in better focus here. Hold on, let me find a good area. The individual cells, oh there, perfect. Look at these guys. The individual cells are wrapped by a layer of basement membrane. You can very distinctly see the outline of each single individual glomus cell. That's really characteristic of this tumor. So if you do like a collagen 4 basement membrane stain, like an immunostain, or even a PAS, it can really light up the wrapping of basement membrane around each cell. Another tumor that does that is epithelioid schwannoma. You can see individual cells wrapped with basement membrane. I don't know if that's really important. It's very pretty though, just so you know. So in any case, that's a kind of a cool and unique feature of glomus tumor. So very nice. These are just such fascinating tumors. And one other little trick that Dr. Weiss taught me about glomus tumors, and I really like, is she said, you know, when you see the nodule of a glomus, if you go out to the periphery of the glomus tumor, often you'll see this. You'll see glomus cells tracking along around additional vessels that are branched out away. They like to wrap and follow the vessels. So even if you go to the edge, you can often see the glomus cells trickling along and following other vessels around out at the side of the tumor. Like, look, right there. Right there. It's leaving that little nodule. It doesn't always do this, but when it does, it's quite satisfying. And it wants to follow this little vessel. It just, the cells know they're supposed to stick along a vessel. So that's kind of cool. And I've certainly had a couple times where that actually helped me in a challenging case of, it was actually a malignant glomus, but seeing an area like that at the edge is what made me think, oh, could this be glomus? And sure enough, with stains, it was. So that is glomus tumor of the stomach wall in this case. Really nice example. Oh yeah, here for anyone who wanted to see, there's our mucosa. So if you're into GI path now, you've seen something other than soft tissue. Okay, now that's enough of that. Back to soft tissue. Okay, case number 3. 25-year-old female with a 10-centimeter deep soft tissue mass of the thigh. When you see a myxoid tumor, myxoma is always a very important thing to think of, right? And certainly this tumor can get mistaken for myxoma, and I've seen that happen before, actually. So myxofibrosarcoma must have one thing. It must have pleomorphism to make the diagnosis. You got, even for the low grade, grade 1, you got to have at least scattered cells that are truly atypical. But these guys, not a bit, right? They are totally bland, little kind of oval to spindled, or even almost round, depending on the angle of the section. Very, very tiny little cells. They're not touching their neighbors. They're like nice and socially distanced, right? They're spread out from their neighbors. They're not making nests or cords or chains. So this is in the muscle, though, of a young adult, and has very delicate, very fine vessels. Look how subtle, and let me find a better area. This slide is a little old and faded, but it's still a pretty good example. Look at this. This vessel is about the tiniest, thinnest little vessel. You can't make a vessel smaller than that. Look, it's one endothelial cell thick, and it only has room for like single red cells. Look, it's like, you remember Rolo formation in multiple myeloma, where they like a stack of coins? The red cells are like making Rolo formation almost, going through. They can only go single file through the vessel. So these delicate vessels that are like one endothelial cell thick that kind of branch, these are the vessels of myxoid liposarcoma. And that's what this is. And this is a really important thing. And I like the fact that, you know, when you think about this and you think, gosh, it looks benign, that is the pitfall of this tumor. Until you've seen one and recognized the pattern, you'd never look at this thing and think it's malignant. It doesn't look anything like the rules we teach for malignancy. There's no mites. There's no pleomorphism. There's no necrosis. It's not even cellular, right? It's hypocellular, bland cells. This is the only one where recognizing the actual pattern of these bland cells in the myxoid background with these delicate branchy vessels. And if you look around, you'll usually find either some scattered mature fat cells or some little tiny signet ring looking lipoblasts. You're not going to see big pleomorphic lipoblasts like you think of for a liposarcoma. And again, that's because this is a translocation tumor. So the myxoid with these very delicate branching vessels, that's the key to always start thinking about myxoid liposarcoma. The vast majority of them occur in the deep muscle of the thigh, like in the quadriceps, you know. And they're extremely rare to see them in the skin or subcutis. I've never seen a case in the skin or subcutis. It's been reported, but I've never seen one. And then they're often in young adults. Young adults or young to middle-aged adults. I've occasionally seen them in old people, and I've rarely seen them in kids too. When kids rarely get rarely get any liposarc, but when they do, this is the kind that they get. And also, one other thing I'll point out is this. See these like pockets of these kind of pools of no cellularity with myxoid stuff in them? So sometimes myxoid liposarc does this. It makes these pools of myxoid background, which are almost totally empty of cells. And some people have likened this to, when there's a whole bunch of this, it looks kind of like alveoli filled with fluid, like they call this the pulmonary edema pattern. It's a little bit reminiscent of what a pulmonary edema like autopsy lung looks like. So that's helpful when you see that to think of this. If you see atypia or pleomorphism, you're almost certainly not dealing with myxoid liposarcoma. These are bland, very benign looking. And here's some, let's see if I can get it in focus. See, there's a little bit of adipocytes in here, a little bit of adipose stuff, some scattered mature fat cells, and then the lipoblasts are going to be like, there we go. Little guys like that. See, he's like a little tiny signet ring. That's actually a tiny little baby adipocyte right there. There it is. Sometimes you'll get ones like this that are multivaculated, but still a very bland nucleus. See, they can sometimes have 2 or 3 little vacuoles, but it's the nucleus is very bland and doesn't look atypical. So that is myxoid liposarcoma, and the translocation that these have is FUS, F-U-S, DDI-T3 translocation. And occasionally, instead of FUS, it's EWSR1, the Ewing's gene, fused with DDI-T3. And that's because FUS and EWSR1 are kind of similar genes. So if you have something that's EWSR1 fused with a different gene, eventually there's a good chance that someone will figure out a rare variant where FUS replaces the EWS and fuses with that same gene, and vice versa, because they kind of play similar roles. So that's a kind of a useful thing. So these are good things to know about because they're really easy to miss if you don't know the pattern. And that's a good lesson Dr. Rowe, my mentor at Houston Methodist, taught me, is if you see something that you think is a neoplasm and it looks benign, but you're not sure what name to call it, don't just sign it out as benign, myxoid neoplasm. Send it to an expert or show somebody, because otherwise you're going to end up missing things that are like these patterns that don't look malignant by the traditional sense, but have a pattern that an expert would recognize and say, oh, for sure, that's this rare malignancy. So I think that's been a really good thing that's helped me out a lot in my practice to stay out of trouble. So that's very good. If sometimes these can turn high grade and become what used to be called round cell liposarcoma, and they'll start getting bigger cells, still uniform, not pleomorphic, and the cells will overlap each other, and then that's like a higher grade form. All right, so myxoid liposarcoma. All right, so case number 4 is a 35-year-old female with a vulvar lesion. This is actually an example of a deep angiomyxoma, also known as a so-called aggressive angiomyxoma. And the name aggressive probably isn't the best name because these are not like aggressive malignancies. They are deep and they are interwoven oftentimes in the soft tissue of the pelvis underneath the vulva, around the vagina, around the uterus. And because of that, they're really hard to remove, and they tend to continue to grow, and they are problematic because of local growth, but they are not malignant in the classic sense of the word. So they tend to have, even though the name says angiomyxoma, and I've only seen a handful of these, to me they often look almost more like edema in the background. It's like pale, but it's not really quite the blue of like real myxoid stuff. And then the other things that can help you here is you can have fat intermingled in them, and you also have vessels of varying size. You'll run everything from little tiny vessels like down here to bigger dilated ones, all the way up to like thick-walled kind of muscular looking vessels and everything in between. So they have this wide range of vascular thickness, and they have kind of variable, cellularity, like low cellularity to very low cellularity. And the one other thing here, let me see if I can find a good area with it. And Mark Edgar taught me this, that you get out here in the midst of these spindle cells, you get these little thin, elongated, like smooth muscle cells. See this like little thin spindle cell that's got a little pink bundle running along? So these little smooth muscle cells are long and very thin, and they're kind of scattered in the middle of this background of bland spindle cells, myxoid, edematous background, and collagen. And a lot of times you'll see those little muscle cells kind of branching off around the outside of a blood vessel and kind of stretching out into the middle space in between the vessels. And so it's a very subtle kind of clue, but it so far has worked out pretty well for me ever since Mark taught that clue to me. And I thought that was pretty nice. You can kind of see one here. See this guy? It's kind of coming right off the wall of the vessel and kind of stretching out away into the soft tissue. Definitely is a very subtle finding. And I guess I should have put there. That's a really nice one. You can see the same thing again. Here's a vessel, and then the little thin, smooth muscle cell stretching away from it. So these will be oftentimes ER and PR positive, but many of the stromal kind of tumors in and near the genital tract have that same kind of appearance. Or, I'm sorry, that same kind of staining can express ER and PR. So the stains alone are not always going to solve a problem for you there. So these are quite rare, and the one thing that helps me a lot is you can see other things with a similar appearance, like fibroepithelial stromal polyps of the vulva. Sometimes you can see areas that look a little like this in angiomyofibroblastoma of the vulva. I feel like all of those stromal tumors that occur in the female genital tract have some overlapping features. The biggest thing that helps me here is these are big, deep tumors. So if you have a small polyp on the vulva, on the labia, with no mass underneath it, it's not this. These are going to be large, deep masses usually. If I have any doubt, like, see, look, this is a huge piece of tissue here. This was part of, like, I think a 15 or 20 centimeter mass that was resected, stretched all the way from the vulva all the way up around the side of the uterus and pushed into, like, the, up towards the peritoneal cavity. So it was quite a large lesion. So anyway, I think that's the biggest thing for me is if I have any doubt, I'll tell the clinician, please do imaging studies to see if there's a mass underneath this. And if it's small, then it's probably not a deep angiomyxoma. And again, my experience with these is relatively limited. I've only seen a few of them, so certainly I'm not the world's expert on them. All right, case number 5. And I apologize, some of these have gotten scratched on the cover slip from years of educational use, which I guess means they've been put to good use. All right, so what do you think about this one? Let's see what the history is. Okay, 55-year-old female. Well, do you know what it is?
Yeah, it's like a paraganglioma.
Good. Yeah, I was going to say I gave away the diagnosis. It's a carotid body lesion. Yeah. Once you know it's right there on the carotid, then what else is it going to be, right? It's usually going to be a paraganglioma. Exactly. And the feature, what is the microscopic pattern?
Zellballen.
Yeah, Zellballen, balls of cells. Although Zellballen sounds way cooler. And basically, by Zellballen, we mean these kind of tight nests of cells. They're round cells arranged into these packets or nests, and they're intervened by vascular channels, prominent vessels, right? See, there's the vessels right there. Now, obviously, depending on where you're located in the body, a lot of other things can be round kind of epithelioid cells arranged in nests, right? Epithelial tumors of various sorts. There's a lot of other things you could think of. Neuroendocrine carcinomas, like carcinoid tumors and stuff like that. So that can be a real problematic situation in some cases. Obviously, when you're in a classic site like right there in the carotid body, well, this is the most likely thing is going to be this. Okay. So what is the, here's the nice nuclear features, right? You've got, let me get, sorry, it's a little washed out. There we go. You get nice, salt and pepper, stippled, neuroendocrine type chromatin, right? That very small speckly looking chromatin. And like with other neuroendocrine tumors, you oftentimes will have random pleomorphism, random large nuclei scattered in the midst of this. So that's a very helpful feature, that it has that neuroendocrine look with the nice stippled chromatin and the random atypical cells. Okay, and then what immunostain, if you needed to do stains, what immunostains would you want to do here?
It's like any type of neuroendocrine marker.
Yeah, synaptophysin and chromogranin will be positive. And then an interesting thing, if you do S100, a lot of times you'll get scattered S100 positive cells around the outside of each of these nests or Zellballen packets, and those are called sustentacular cells. I have seen occasional times where it was clearly a paraganglioma, but that stain didn't work very well. So when it works, it's great, but I feel like it doesn't always work as beautifully as it's illustrated in the books, let's say. And then usually keratin will be negative, but sometimes you can have some keratin expression. And the reason that's important to know is that can lead people to make a diagnosis of neuroendocrine carcinoma. And I've seen that happen where a paraganglioma got confused with neuroendocrine carcinoma. And obviously that's very different implication for the patient and potential treatment. And one place in the body where particularly paragangliomas tend to have a lot of keratin is near the sacrum. Sometimes paragangliomas occur right around the presacral area or in the filum terminale region, and they can have a lot of strong keratin expression there and totally make you think of a metastatic neuroendocrine carcinoma. So that's a really important pitfall to be aware of. What is the diagnostic malignant feature? How do you know if a paraganglioma is benign or malignant?
Metastasis.
That's really it, as far as I know, and I'm not the top expert on paraganglioma, but my understanding is basically we can't look at them and figure out from mitoses or nuclear pleomorphism. The typical things that we try to use to predict how tumors will behave don't work here. We only know if they're malignant once they metastasize. So that's the main thing that we know, and a significant subset of them, depending on whether it's in the carotid area or if you have one in the adrenal, a subset of them will metastasize. And what is what's the special name you give to this tumor if it occurs in the middle of the adrenal gland? Pheochromocytoma is basically the same thing as paraganglioma. The only difference is the name is if it's outside of the adrenal, then it's called pheochromocytoma. They are basically the same tumor. Okay, and so some paragangliomas are associated with a syndrome. They have a syndromic association. A lot of those syndromes are related to germline mutations of SDH, succinate dehydrogenase gene. And also occasionally you can see them in association with neurofibromatosis type 1. So good to know about that subset of paragangliomas and pheochromocytomas are syndromic, and the rest seem to be sporadic. So a good example of paraganglioma and pheochromocytoma would look identical to this, but it'd be in the adrenal medulla. Okay, so let's see case 6. All right, so what did you think this one is? Oh, I guess I got to pull out history. Well, you can read me. What's the history?
This is a 25-year-old female with a rapidly growing 3-centimeter forearm lesion.
Okay.
It's like a encapsulated nodule with lots of like a tissue culture appearance, like a spindle cell growth, a fibroblast.
Yeah.
Which it's suggestive of especially the clinical course, suggestive of nodular fasciitis.
Yeah, that clinical of a rapid growing but relatively small lesion, often on the extremities of a young adult, although it can occur in kids, it can occur in old patients, it can sometimes be on the head and neck. Those are always, though, a good history for nodular fasciitis or other related entities. And like you said, the lesion, the classic areas are like this, these feathery tissue culture kind of areas which are made of these plump, spindled and stellate myofibroblasts with a background of kind of loose myxoid change and a little bit of collagen. And that's this is what people describe as tissue culture. And the idea is that it looks similar to what fibroblasts look like if you're growing them in a cell culture dish, which I've never done. So I feel like the tissue culture name works well if you've worked in a lab where you've grown cells in a culture dish. But for a lot of people, they may not know what that looks like. So to me, I think this looks kind of loose and feathery. Those are the kind of visual terms I use. And I find one of the most helpful features to be the presence of these cystic myxoid little microcysts. Cystic degeneration with myxoid change is really classic and present in the majority of cases of nodular fasciitis that I see. Sometimes it can be even bigger cysts. And then the cellularity can vary from being really cellular towards more kind of low cellularity as the lesion gets old and kind of burns out. Also, as the lesions kind of get older, you tend to see more sclerosis and a more abundant collagen in them. So they can run a range of features. And the cells they can be kind of plump, but they should not have severe atypia or nuclear pleomorphism, although occasionally you can see these kind of ganglion-like cells like you see in proliferative fasciitis or proliferative myositis, and those can look kind of weird and scary, but you don't want to see big hyperchromatic pleomorphic nuclei here. Mitoses are common, and they can be abundant, but you usually do not see atypical mitotic figures. And sometimes you see keloidal collagen, multinucleated giant cells, red cell extravasation. I don't personally find that helpful, but I know a lot of people really like to see that, and it is usually present. So, and usually nodular fasciitis is a small lesion, 3 centimeters or smaller usually. If it's bigger than 3 centimeters, you should really think twice before calling something nodular fasciitis. It's not that it couldn't be. I mean, could you have a 4 centimeter nodular fasciitis? Sure. How about 5 centimeters? Yeah, probably. What about 15 centimeters? No way. So the point is the bigger it is, the more likely you are to be wrong. So I feel like 3 centimeters is a pretty safe cutoff. Beyond that, start really thinking twice. And then usually nodular fasciitis arises from the fascia, right? So thus the name. And we call it fasciitis, and the itis name makes people think it should have a lot of inflammation. I feel like it usually does not. You might find some scattered lymphocytes and histiocytes in there, but it is not usually a highly inflammatory or inflamed lesion, despite the itis name. So I think that's important, that a lot of people expect there to be inflammation, but usually there's not much inflammation. And out here, look, this is fascia. See, it's spindle cells with dense pink collagen, and so pink spindle cells in a bundle is either dense regular connective tissue, which is tendon, fascia, or ligament, or it's smooth muscle, or it's nerve. And in this case, we can see that it's super wavy, and the real waviness, that ultra wavy collagen bundles, is not nerve. It's actually what we see in fascia or tendon, usually the dense regular connective tissue. So here's your fascia right here. Here's skeletal muscle right there. And here's the nodular fasciitis coming right off of the fascia. So often, you don't have to see the fascia there. It depends on if they've sampled it or not. But usually when nodular fasciitis grows on the fascia, it does one of 3 things. It can either make a nodule that pushes up into the subcutis, or it makes a nodule that pushes down into the muscle underneath, or sometimes it grows linearly out along the fascia and kind of sends little spikes or little feet up into the subcutaneous septa, and it kind of stretches in and looks kind of spiky and irregular. That's called the fascial pattern because it grows along the fascia. So that's good nodular fasciitis tips. Here is nodular fasciitis involving the lumen of a vessel. Do not be afraid, that happens. And in fact, you can see some cases of nodular fasciitis are purely intravascular, and they actually may be closely related to organizing thrombus, which also can look a little fasciitis-like. So that is not a sign of malignancy. In a lot of tumors, if we see tumor or cells in a vessel, we get really worried. But in nodular fasciitis, that happens. The other thing is that nodular fasciitis, even though it looks a lot like, almost identical to what reactive myofibroblasts look like say in granulation tissue, it turns out is actually probably a neoplasm because it has a rearrangement. And what genes are rearranged in nodular fasciitis?
MYH9 USP6.
Yes, MYH9 USP6 fusion has been described, a translocation. So for years we thought that this thing was a reactive process because it often arises after trauma. It often goes away on its own. It looks like reactive myofibroblasts, and yet it seems to have a translocation, which is kind of blows everyone's mind. It's so weird. But it seems like that's the case here. And do you know there is actually another process, not in soft tissue, but in bone, that has that same exact fusion sometimes. aneurysmal bone cysts,
Oh.
which have areas that look like fasciitis. They often have, not all, but a majority of them, I think, have that same fusion, which is kind of interesting, especially because you can see this fasciitis-like appearance in that entity. So I really almost never need to test for that, although I've occasionally tested for it in cases where I was thinking about aneurysmal bone cyst versus other things. But for nodular fasciitis, I don't think I've ever actually sent it for molecular analysis. So, and here's some of that example of the keloidal collagen bundles. So I do like to tell my clinical colleagues that nodular fasciitis is benign. Sometimes it will regress on its own even. So even if they shelled it out and the margins are positive, it usually does not recur. Occasionally. So if I'm confident of the diagnosis, I feel like even if they didn't get the whole thing out, I feel like it's optional to excise it. They can watch and wait, and it usually will go away, or sometimes it will go away on its own. If it doesn't go away or it does persist, they can go do more surgery. But I don't feel like a complete excision with negative margins is indicated. I think you don't have to do that. So that's just my personal view. I'm not trying to tell anyone what they have to do, but that's the way I kind of think of it and how I advise my clinical colleagues who are treating patients. And there's an example of tissue culture plus myxoid cystic degeneration plus hemorrhage, extravasated blood cells plus keloidal collagen, all the stuff in one picture. Nodular fasciitis. Because of the mitoses, sometimes people get concerned, especially the early cellular lesions of these, and can overcall them as sarcoma. And that's really important to not do that for obvious reasons. All right. Now, case 7, we've got
60-year-old male with a rapidly growing 3-centimeter shoulder lesion.
All these red bundles here are skeletal muscle. And then in between the skeletal muscle is something else, right? Spindle cells.
Yeah.
Maybe a slight bit of bluish myxoidy backgrounds.
Yeah.
This pattern is very interesting, isn't it?
Yeah.
That the spindle cells are kind of filling in the spaces between the muscle bundles, and they're actually splaying apart the individual muscle fibers, right?
Yeah.
It's kind of a weird thing. Let's go look closer.
Some area cells get like wrapped a little bit.
Ah. I think I know what you're talking about, like in these areas.
Yeah.
So here, in the midst of the skeletal muscle cells, in the background here, we've got these cells that have abundant eosinophilic to purple kind of amphiphilic cytoplasm, large round nuclei, and big central nucleoli. And they do have kind of a rhabdoid appearance, which is scary, right?
Mm.
And if we look around, there probably are mitoses in here. What about these cells here? What does these cells kind of look like? This area, this kind of loose, a bit hypocellular,
Yeah.
kind of spindly to stellate cells. If you ignore those big, huge cells floating around in here, I think this background looks kind of myxoid. I think it kind of looks like nodular fasciitis a little bit.
Yeah.
There's extravasated red cells. So to me, that's the trick with recognizing this, is that if you can look away from the big eyeball-looking cells staring up at you, which are admittedly very scary, the background looks to me like myofibroblasts with a purple cytoplasm, spindle to stellate, kind of hypocellular in a myxoid background, extravasated red cells. This is actually a form of fasciitis. This is called proliferative fasciitis.
Oh, wow.
And it is a very scary looking process, and one that has caused many people to overdiagnose it as sarcoma. In fact, early in my career, I actually called a case that I thought was sarcoma, and it was just a really robust case of proliferative fasciitis, where all of those big ganglion-like cells, that's what we call those big cells that look kind of rhabdoid, they were all packed closely together, and it wasn't in the muscle, it was in the subcutis, so I didn't have this clue to go on. So the one clue is that the cells, if you ignore the ganglion-like cells, everything else kind of has a fasciitis look. It's hypocellular, usually. There are exceptions, like that case I mentioned that I had trouble with early in my career, and thankfully nothing bad happened to the patient, and it was a good learning lesson, but it was a little scary. And that was after I had done a soft tissue fellowship. So I still struggle, and I thought about proliferative fasciitis, but I thought just too much. And particularly in kids, when kids get proliferative fasciitis or proliferative myositis, is the same thing. We just use a different name. If it's centered in the subcutis, we call it proliferative fasciitis. If it splays apart muscle like this, we say proliferative myositis. But in kids, there's a form that is very cellular and has a bunch of those ganglion-like cells, and that is pretty scary looking, for sure. Very scary looking. So, but this pattern from low power is so key. The proliferative fascia or myositis, when it's in the muscle, it splays apart each individual skeletal muscle fiber and the whole groups of fibers, and that is an uncommon pattern for sarcomas to do. Sarcomas, high-grade sarcomas, usually grow rapidly and push everything out of the way. They make like a big ball of tumor and have actually smooth, not infiltrative borders, with a few exceptions. One of the most notable exceptions would be myxofibrosarcoma. Myxofibrosarcomas can look a bit like this. They have a myxoid background, just like the fasciitis does. They infiltrate between muscle, just like this does. Although I would say that they might do this focally, but the fact that every single muscle here is splayed apart perfectly, that's very characteristic of proliferative myositis. And in fact, this, if I recall this case, this was actually one of the flat muscles on like the forearm of an older patient, and the whole muscle was completely replaced on imaging. And that actually in flat, thin muscles, that's a characteristic feature. And the radiologist knew. They said, oh, this is going to be proliferative, or they knew it was going to be myositis because it's like the whole muscle gets replaced. The other thing that helps is this is the whole lesion. There is no like central mass. Like most sarcomas, even if they infiltrate, they'll have a central area that's tumor, definitely. And then at the edges, they'll trickle out like a myxofibrosarcoma. But here, there is no like center, right? The whole thing is like a patchy quilt, like a quilt of weird splayed apart muscle and fasciitis, and weird muscle and fasciitis all patched together, right? So I find that it's kind of, some people call this a checkerboard pattern. So it's kind of this checkerboard pattern, and the way the muscle splays apart from low power is super helpful. At higher power, you'll see stuff that looks like fasciitis, which is why studying what reactive myofibroblasts and nodular fasciitis, again, both of which look very similar, studying what myofibroblastic things look like is so important, because it will help you to recognize this looks kind of reactive fasciitis-like in appearance. And then once you see the big, huge cells with the big nucleoli, that's what makes this proliferative myositis, is the presence of many of these ganglion-like cells, which are probably just weird, reactive-looking, a weird pattern of myofibroblast. But those cells are the typical cells of this. So yeah, if you're not seen this before, and even if you have seen it before, it is a scary-looking process. And you can see those ganglion-like cells occasionally in regular nodular fasciitis, just a few of them. And you can see it in other things like myositis ossificans sometimes. So it's a really good thing to know about and be aware of, because it's real easy to get tricked. Let me find there. That's the good area, so that we can have a nice close-up view to see the ganglion-like cells. They're real prominent nucleoli. And like you said, I like your description. They really do have kind of a rhabdoid look, an eccentric nucleus and abundant kind of purple cytoplasm here. But those are the ganglion-like cells of proliferative myositis. And again, if it was not in the muscle, we'd say proliferative fasciitis. So that's a really good thing to know about. Very tricky case that is challenging and benign. Okay. So all of the weird benign things that can look malignant, those are all good things for us to learn about, because they're pitfalls that are really easy to fall into in practice. And sometimes you'll see some myxoid cystic degeneration and little focal breakdown, just like you would in nodular fasciitis. And here's more a pocket of those ganglion-like cells. And that's the other thing that helps me is the hypocellularity. The fact that the cells are kind of spaced out. Most sarcomas, the cells are packed close. Again, an exception can be some forms of myxofibrosarcoma. The cells can be floating around in a myxoid background, and those cases can be quite challenging. So, all right. Now, case number 8. Hip mass in an 80-year-old man that's painful. Here's skin up here. And we're down in subcutis. And then way down below that, at the bottom of the subcutis, we got something that's kind of replacing and filling in the space where the fat used to be. So that does have fat entrapped right in the middle of this lesion. So quite worrisome, because it looks like it's being replaced. The fat is being replaced by spindle cells. But let me point out, what does this look like? but with big nucleoli, and they look just like those ganglion-like cells in the last case. And look at the background cells, myofibroblasts with purple cytoplasm and spindle to stellate look. See like how that guy's kind of a triangle shape? That's what stellate is, kind of triangle-shaped cells. Even though stellate means star-shaped, they never have like a 5-point star. They're always like kind of 3-pointed triangles. But that pattern, that growth pattern, purple cytoplasm, triangle shape, very characteristic of myofibroblasts. And we've got background myxoid change, and we've got extravasated red cells. If I took those big cells out and just showed you this looks like nodular fasciitis. Take away the big ganglion-like cells, this is another form of fasciitis. Very scary, right? It looks like it's infiltrative and replacing the fat. But this is one where we've got stuff at that periphery that looks like fasciitis. We'll come back to the fat involvement in a minute. But then when we go to the center of it, look what something different happens here. In the very middle, we've got a zone that's not bluish and myxoid anymore, but red. And when we go closer, it's all dead. It's necrosis. It's necrosis that kind of all the tissue's dead, but it also looks kind of like fibrin. So what we call this is fibrinoid necrosis. It's like kind of, I think of it as a necrosis where there's been extra blood bleeding into it, or it looks like that. So it has that bright red color of fibrin, but it's all dead. So it's this kind of fibrin necrosis overlap. So this lesion, I wish I could show even lower power, because the key to recognizing it, aside from the clinical history, which is important, is the fact that it's zones. It has a central zone of fibrinoid necrosis. Then the periphery around that zone looks kind of like fasciitis, has kind of a nodular fasciitis, myofibroblast with a myxoid background look. And then as you get out to the periphery, depending on the age of the lesion, that stuff will begin to kind of mature and turn into scar tissue. And we're kind of seeing that happen here. The fasciitis is kind of starting to organize and actually making like more fibrous kind of scar tissue, like right here. See, it doesn't look as loose and myxoid and granulation tissue like anymore. It's now starting to kind of look scar-like. And you'll often see kind of proliferating blood vessels out in that area around the outside too. So that, they're like right there. That looks like granulation tissue, see? It's kind of like that proliferative revved up vessels and reactive myofibroblasts that you'd see in granulation tissue. So the zone of ischemic type fibrinoid necrosis in the middle, surrounded by fasciitis and granulation tissue, surrounded by scar, that is typical of ischemic fasciitis. That's what this is, ischemic fasciitis. It is totally benign. Well, it is not malignant, but I mean, it is a problem. When people get this, it kind of is a similar process to decubitus ulcer, okay? And the other name for this is called atypical decubital fibroplasia, which basically it's a reactive fasciitis-like change that occurs in the setting of chronic pressure, just like decubitus ulcer, often in older patients that are bedbound over bony prominences like the sacrum, the hips, sometimes the shoulder, the elbow. I've seen it occasionally in those places where the bony prominence is pushed down for hours and hours on end from someone who's confined to a wheelchair or a bed or something like that. So oftentimes that's the finding. And the idea is that that pressure pushes the blood out of the tissue and causes ischemia, and eventually the tissue dies. And what you get is the fibrinoid necrosis from the ischemia. Then the response around the edge of it is all reactive, reparative, fasciitis-like reactive myofibroblasts and granulation tissue and scars trying to kind of repair around that central zone of dead tissue. That's the way I kind of conceptualize it. It's all this. This is the ischemic center, and all the stuff around it is kind of reacting to it. So the thing is to recognize that zonal pattern, which is, if you have a small biopsy, you may not be able to see this, and it can be quite challenging. But if they go in and take enough tissue out, you can see this ischemia and fibrinoid necrosis, and then that zone of fasciitis-like stuff and granulation tissue-like stuff around the edge. And it sometimes has ganglion-like cells, just like you can see in proliferative myositis, proliferative fasciitis. There they are right there. Those are the ganglion-like cells again. And the fat is just kind of caught up in the middle of it. But you're right, the appearance is very much like what you would see in you could think about a tumor that's got fat, like a liposarcoma, well-depth liposarcoma with myxoid change, or atypical lipomatous tumors. Certainly, you could think of that. You could also think of like a myxoid-looking DFSP at low power, although the cells here are much bigger and more plump. DFSP usually has very thin, stretched-out cells, kind of neural-looking, not these big plump myofibroblasts. So that's one thing that would help you there. And also, if you did CD34, usually much of the lesion, except for the vessels, will be CD34 negative most of the time. And these areas here, these are actually look really scary. But there are some ganglion-like cells intermingled with really juicy, revved up endothelial cells. See, they're starting to make new vessels, just like the vessels in really robust granulation tissue. So that can look really scary. So again, this is a good reason whenever you have a biopsy site or something that's really revved up and you know that it's benign and reactive granulation tissue, study that and get used to when you know it's granulation tissue, study it closely, and you'll get used to just how weird myofibroblasts and vessels can look when they're reactive. Because otherwise it's really scary. So these can be large, and so clinically they can be concerned that this is going to be a sarcoma, especially if they don't actually have a decubitus ulcer over it. It's just a mass underneath. So the surgeons will often be worried that this is a growing mass, and they'll think, because it can be kind of large, they will often be concerned that it's a sarcoma. So this is one of those times it's scary looking microscopically, and then clinically their concern is for malignancy. So it can kind of lead to it feels like there's a clinical pathologic correlation, but it's both sides are wrong, right? It clinically looks more scary than it is, and microscopically. So that is called ischemic fasciitis. And again, recognizing the loose myxoid fasciitis-like stuff in the background, that pattern is what really helps me a lot, in addition to the zonal pattern. And here's another area that's kind of really scary looking. This is just really revved up vessels. Look at that. And he's got a mitosis. I mean, that looks very, if you just took a high power picture of that, I mean, anyone would be terrified. You'd think, oh, that's bad. But when you put this kind of reactive vessels and myofibroblasts in the context of the background stuff that all looks like fasciitis, and this is totally fine. So when we go up to lower power, that's just with focus. But I've shown this slide to many residents and students over the years, and usually people think it's malignant. They usually think it's either liposarcoma or DFSP or myxofibrosarcoma. Many of my fellows I've shown, I've had a lot of people I've been able to trick with it because it's a very robust and scary example. But that's the kind of stuff we want to see, and in our training, right? We want to see stuff and struggle with it and get it wrong, so then we remember it in the future, because yeah, that's pretty wild looking, right? So ischemic fasciitis, really, really characteristic, great example. Now 1-9. Okay, and the history here is a
10-year-old female with multiple soft tissue nodules.
All right, 10-year-old female, multiple soft tissue nodules.
Plexiform neurofibroma.
Yeah, it sure looks like it, doesn't it? So big multiple nodules and elongated trunks of tumor connecting together. In the middle, we're down here like near the fat and near the muscle, so kind of in the deep subcutis. And then when you go closer to, one of these individual nodules, you'll see oftentimes in these big, deep plexiform neurofibromas, that's when you'll see like the shredded carrot pattern. I feel like in neurofibromas in the skin, cutaneous little nodular neurofibromas, you don't often see this very well. But the big plexiform ones, you see these little thin wisps of collagen, a little bit of loose myxoidy background, and then small bland Schwann cells scattered in there, and fibroblasts and perineurial cells all mixed together. You can't see the difference between those usually, but on staining we know that there's several different cells that go into a neurofibroma. And each of these used to be an actual nerve trunk that's been kind of filled up and expanded by the growing neurofibroma inside of it. So that what happens is these are actually individual nerves that are so distorted and blown out of proportion. So if you actually do like a perineurial marker, a lot of times you'll see like EMA or GLUT1 or claudin around the outside. I mean, you don't have to do that, but if you do that stain, you'll often see that each of these are well-formed nerves that have just been grossly distorted by the neurofibroma. Okay? Sometimes also you can see background diffuse neurofibroma intermingled with the plexiform. So what does this patient have? What disease?
Probably neurofibroma.
Yeah, basically, when you tell someone that they've got a plexiform neurofibroma, you are giving the person neurofibromatosis. So that is why we have to be very, very careful to be totally sure before we ever make that diagnosis. Even though, and here's the kind of S-shaped, those are Schwann cells. They're kind of S-shaped or buckled, bent, crooked. Another Mark Edgar thing that he taught me is he said that they look like, if you take a can of Coke and you open the can, and the little tab on the can is like kind of bent. It's kind of crooked. I like that because sometimes they look S-shaped, but I think more often they look bent, like someone pushed their finger in the middle of it and just bent it in right in the middle and dented it in, or like those little pop tops on the tabs on the can of Coke. And I love, again, one of the other many, many visual clues that Mark taught me, and I thought that was so exactly what they look like, right? I was like, oh, that's so perfect. So that's a kind of a typical thing of Schwann cells, all right? And again, myxoid background change, really common in neurofibromas of all types. Sometimes it can be really abundant. So the only time to definitively diagnose something as a plexiform neurofibroma, I want to know at least one of two things. Either number one, this thing grossly had a bag of worms appearance, right?
Yeah.
Like snake-like, tortuous nerves tangled together and looked like a bag of worms grossly, or on imaging that they were sure this is plexiform appearance. I either need to know that for sure, or I need to know the patient has NF1. Because otherwise, there are other entities, including some neural ones, that are multinodular but are not truly plexiform. Palisaded encapsulated neuromas can be plexiform appearing, and have this same multinodular look microscopically. Schwannomas can also be a multinodular schwannomas, or what we call plexiform schwannomas, but they don't have the association with NF1. So this pattern really is very characteristic, but there are some other tumors that can mimic it. And if you call one of those plexiform neurofibroma, well, guess what? You've labeled a patient with NF1, which means that you've given them a 50% chance of passing on NF1 to their kid. And so it's a really important thing to make sure that we're really careful and cautious about. And then if I think it looks like that, but I don't have that info, then I'll talk to the clinician and say, hey, this is concerning for a plexiform neurofibroma. Could this patient have NF1? And then they can do a more thorough clinical exam or a genetic counselor workup to see if the patient actually has it. So that is, and usually these are big, deep masses, not usually in the skin unless they're coming up from deep soft tissue. All right, so plexiform neurofibroma. All right, finally, case number 10 is a 15-year-old male with a skin nodule on the leg. Now, I didn't let you preview this one, so I'm going to explain it. Here is the skin surface. Let's see if I can get it right side up. And then down here in the deep dermis and extending way down into the subcutis, we've got a spindle cell proliferation. It's pink. You can see that it encases many of the eccrine coils here. And if we look closer at the cells, they are bland little spindle cells. They've got some fine, delicate collagen in there and a little bit of a pale kind of myxoid background slightly. This slide's a little bit faded. But it's a very pale kind of appearance. And then let's look down deeper. You can see that there's some entrapment of fat. Again, entrapment of the eccrine coils. Actually, a lot of fat entrapment. And in a way, it has a very kind of honeycomb appearance. All right? So for those of you watching at home, what do you think this is? I'm going to go closer and see if you can figure it out. And if you did CD34 staining here, it would be strongly positive. So the temptation would be to call this dermatofibrosarcoma protuberans, DFSP. It's got honeycomb fat entrapment. It's got bland spindle cells. That's the stuff that DFSP has. But the problem here is that it's actually also S100 positive. This is a diffuse neurofibroma, which can often entrap fat, sometimes extensively. And I think it's really important to know about this because a lot of people forget that neurofibromas often express, the majority of them will express CD34 because there's a background dendritic cell component. This case also has a couple of these little like elongated, expanded nerve trunks, which are also filled with neurofibroma. And in fact, this patient had NF1, unfortunately. And so this is a tiny little bit of plexiform neurofibroma mingled in with this diffuse neurofibroma. And again, I would never, without any clinical information, would never say, oh, that's plexiform neurofibroma, but this patient did have NF1. And in reality, you often do see in NF1 patients diffuse neurofibroma intermingled in the background between the trunks of plexiform neurofibroma. And I don't know if there was a larger, deeper plexiform neurofibroma under this or just a few kind of expanded branches there. But I find those expanded nerve trunks really helpful to recognize. You don't always see this, but if you see something like that in a diffuse neurofibroma, I mean, that would not be something you would see in dermatofibrosarcoma protuberans. And again, doing SOX10 or S100 is going to confirm that this is that there's a Schwann cell component to this lesion. And unlike schwannomas, which are completely composed of Schwann cells, there are often fibroblasts and perineural cells in addition to Schwann cells in a neurofibroma. So not every single cell in a neurofibroma is going to usually stain with S100 and SOX10. It'll be many of the cells, but there will be a background subset of cells that are negative, and those are the fibroblasts and the perineural cells, which are present in varying amounts. But this is a really good example of just how incredibly diffuse the growth pattern can be. I wish I could go even lower power, but eventually I will scan this slide, and if you're watching this online, look down in the video description and you'll be able to eventually see a link to this, and you can then explore for yourself and see just how extensively infiltrative this lesion is. So not all diffuse neurofibromas look like this, but sometimes they do. So entrapment of fat and also entrapment of the eccrine coils can be seen in diffuse neurofibroma, and particularly when you have NF1 patients with large diffuse neurofibromas, you can actually see it extend down into the muscle and really involve vessels and normal structures deep down, even below the subcutis. So they're benign but can be quite disfiguring. And there's one thing that I wanted to show you, but this particular diffuse neurofibroma doesn't have. But there is a structure that is usually present, but not always, usually present in diffuse neurofibroma. So I'm going to cheat and pull a different case here because this case has a very good example of this structure. And what you see are these little spindle cells that are kind of wrapping around each other, kind of oval to spindle to round cells wrapping around each other. And in the middle, they have little pink centers that are little pink layers, like little stacked layers of collagen. You can see there's a cluster of them here, here, here. Sometimes they're single, but sometimes they're in little whorled clusters like this. And again, if you flip your condenser, you can see they're made of little flaky layers of collagen. Here's another one right here. And if you're watching from home, does this remind you of any structure you've seen elsewhere in the body, perhaps? And here's more of them. There's a whole cluster of them. Here's like 50 of them. These are called Wagner-Meissner bodies, and they are very similar to what you see in a Meissner's corpuscle, the fine touch receptors that's in the papillary dermis, on the fingertips and the toes, right underneath in the dermal papillae. There are these little round structures that are kind of Schwann cells wrapped around a center that looks like little layers or stacks of collagen. I used to think they looked like kind of striped pink Easter eggs. And one of my histology colleagues at a former job that I had said that they reminded them of cotton candy. And I thought, oh, that's nice because it's loose and fluffy and swirly. So it's like, imagine 50 cotton candies stuck together here. So these are Wagner-Meissner bodies. And again, if you just take one of these, it very closely recapitulates what you see in a Meissner's corpuscle in the skin. In the papillary dermis. So when you find those, that's a nice clue for the diffuse type of neurofibroma. They often have those, not always though. That's a pretty robust example. This is a different case, which we'll have to leave for another day, but I will point out that occasionally diffuse neurofibromas can actually have a prominent round cell component. And see, these are not as spindled. These cells, they're still Schwann cells, but they're actually very round, kind of oval to round, and they can get to be actually even kind of hypercellular in some areas, like up here and there. I think maybe on another slide there even, another portion of the slide there even more. So they can even start making you think about like a round blue cell tumor, but they still are usually spaced out a little bit, and the cells are totally bland and have almost no mitotic figures. But just know that diffuse neurofibromas actually can have kind of a rounded cell. And I remember the first time I saw this when I was in fellowship, I thought, how is this a neurofibroma? The cells are round. But in fact, that does happen, and it's a known thing. And this patient was also an NF1 patient, unfortunately. And like all neurofibromas, there are often little mast cells floating around in that background, because the background of neurofibromas and some other neural proliferations often has a bit of a kind of hyaluronic acid, glycosaminoglycan, myxoid or mucin substance, kind of very delicately intermingled between the Schwann cells and the collagen. And wherever the mucin or myxoid stuff is, mast cells tend to like hanging out there. So another diffuse neurofibroma with some really nice Wagner-Meissner bodies. Oh, and I forgot to mention that you can also see things that look just like Wagner-Meissner bodies. Oh, and isn't this cool? I thought this one was neat, that it's got like kind of tiger stripe pattern of like almost like it wants to palisade or something. That's the only case I can personally remember having seen that did that. And I thought that was a particularly fascinating finding. But the these Wagner-Meissner bodies, you can see nearly identical structures in neurotized nevi, like congenital pattern nevi that are very thin and spindly, type C melanocytes. You can get structures that look just like this and are Wagner-Meissner-like, or I think the other name for them are Masson bodies or tactoid bodies, because everything has to have several names in dermpath, you know. So that is an example of diffuse neurofibroma. And do remember that the fat entrapment, the honeycomb pattern, is not always DFSP. And if you're thinking DFSP, don't just do CD34. Add an S100 because it's exceptionally rare for S100 to be positive in DFSP. All right, well, thank you so much for watching this video. And Iman, excellent job on these cases. And I hope you all enjoyed.